Several years ago,
Sorry.
no
We have to
problem.
introduce ourselves again. Did you hear us introduce ourselves, or should we do that again?
Nope, you gotta go back to the beginning.
Sorry.
Okay. Hi, everyone. I'm Pam Guerrerio. I'm Chief of the Laboratory of Allergic Diseases at the NIH.
I am Tony Guerrerio. I am a pediatric gastroenterologist at Johns Hopkins.
And we just wanted to apologize for the technical difficulties. We're really looking forward to spending part of our evening with you and answering any questions you have. So we're going to get started. Sorry about the late start. We should be faster at this point in the pandemic, but it's still some progress, I guess. So several years ago, we showed that people with Loeys-Dietz syndrome are more likely to have allergic disease than people in the general population. But it's important to note that this study really focused on people with type 1 and 2 LDS. We don't know whether people with other forms of LDS have this same predisposition, although that is something that we are actively investigating now at the NIH. The most common form of allergic disease to affect people with LDS, as well as people in the general population, is allergic rhinitis. The most common symptoms of this condition include runny nose and congestion, sneezing and coughing, which in some people can worsen their asthma symptoms, and then itchy, watery eyes. For some people, these symptoms are most prominent at certain times of the year during the peak of the pollen seasons. But for people who are allergic to mold and pets and dust mites, they can have symptoms that are year-round. Asthma was also more common in people with Loeys-Dietz, affecting about 40% of our cohort compared to about 10% of people in the general population. Asthma is a condition where there is inflammation in the airways that leads to increase in swelling and overproduction of mucus. There's also tightening of the smooth muscles around the airways, and that can make it difficult for air to get in and out of the lungs. Asthma attacks can be triggered by a number of different exposures, including allergens, cigarette smoke, and other pollutants, cold air, exercise, and certainly at this time of year, viral infections. The most common symptoms of asthma include cough, especially a dry cough at night, wheezing, tightness in the chest, and shortness of breath. Our current treatments for asthma right now are really focused on trying to relax the smooth muscle around the airways to allow more air to enter, and then treating the underlying inflammation. In our experience, we found that chronic sinus infections can be a major contributor to asthma in some people with Loeys-Dietz syndrome. We don't think that people with Loeys-Dietz syndrome are more likely to infections in general. It really seems to be more specific for sinus and in some cases ear infections. And the reason for that is we think the differences in the skull, the bones in the skull, that make it more difficult for the sinuses to drain properly, and that can predispose to infection. We found that aggressive treatment of the sinus disease, which in some cases can involve several weeks of antibiotics, often leads to a very dramatic improvement in asthma in people with LDS. Eczema, which is also known as atopic dermatitis, is also quite common in people with Loeys-Dietz syndrome. This is a chronic skin disease characterized by redness, dryness, and as you can see, inflammation and extreme itchiness in the skin, as you can see in these pictures here. The primary treatment of eczema is really focused on one, trying to improve the hydration of the skin, and two, topical treatments that will reduce the inflammation. Almost 1/3 of people with types 1 and 2 LDS will have food allergy. It can be really tricky to diagnose food allergy and distinguish it from food intolerances, which are also very common both in people with LDS and the general population. What really distinguishes food allergy is that it is an immune response to a food protein, whereas most food intolerances are related to the carbohydrate content of food. A good example is lactose intolerance, where people are missing the enzyme that's needed to break down lactose, one of the sugars that's in food. With food allergy, even very tiny amounts of the food can cause a reaction, and in some cases, these reactions can be severe and even life-threatening. Some people are only allergic to 1 or 2 foods, but it's certainly possible that you can be allergic to multiple foods. It's important to know that our current tests for diagnosing food allergy often give false positive results. And what that means is that many people will have a positive test to a food, whether that's blood testing or skin testing, even when they're not truly allergic. So it can be really important to consult with an allergist when interpreting the results of these tests to really know for sure which foods you need to avoid. At this point, we don't have a cure for food allergy, and current management is really strict avoidance of the food with ready access to an epinephrine autoinjector or EpiPen in the event that you have an accidental exposure and reaction. Now, epinephrine works by increasing blood pressure and the heart rate, which are not desirable effects in someone who has an underlying vascular abnormality. And so we are more cautious about using epinephrine in people with Loeys-Dietz syndrome. This can be important to discuss with your school nurse. Generally, we would recommend that local or localized or mild reactions at least first be treated with an antihistamine, and that we really reserve use of epinephrine for those reactions that are more severe, such as if someone's having difficulty breathing or if they have involvement of 2 or more body systems. So the symptoms of food allergy can range from chronic low-grade symptoms that might just involve the GI tract to acute, more life-threatening reactions. Some common features that you can see during a food allergic reaction include hives and swelling, cough and trouble breathing or wheezing, and then in the most severe cases, hypotension or a drop in blood pressure and shock. Now, in these very severe cases, whether you have Loeys-Dietz or not, we would strongly recommend using epinephrine since the benefits will far outweigh any potential risk.
So another kind of food allergy, which is more thought of as a slow motion food allergy. So while this is a food allergy similar to those that can cause hives or trouble breathing or anaphylaxis, these are more thought of as a slow motion food allergy. The important thing is that the mechanism for how this allergy happens is very different from the anaphylactic or IgE mediated food allergy that Pam was talking about. It causes an eosinophils, which are a type of white blood cell that's associated with allergy, to move into the tissues, most commonly the esophagus or the food pipe. It doesn't turn into anaphylactic food allergies, and the blood or the skin tests that Pam mentioned are not helpful to tell you what food is causing eosinophilic esophagitis. It can only be diagnosed by an endoscopy with biopsy, and it can cause symptoms such as reflux, trouble swallowing, or food getting stuck. Also in connective tissue disorders, and in some people with Loeys-Dietz syndrome, they can have weight gain can be problematic. So this is also seen in Marfan syndrome as well. It can also be complicated if there are underlying allergies or inflammatory conditions such as eczema. And one of the things one of the situations that is important to pay attention to is if you have an upcoming surgery. So if you know that you're planning a surgery for the upcoming summer or something along those lines, it would be really important to talk with a dietitian or a gastroenterologist to see what can be done to maximize your nutrition, to get your body mass index, your weight for how tall you are, into an appropriate range, because having good nutrition going into a surgery leads to a lower risk of complications and a faster recovery. So if you have a body mass index or a weight for how tall you are that is dropping percentiles, if it's consistently below the 3rd percentile, if it's below the 10th percentile and a surgery is planned, you want to talk to someone about how to supplement in such a way that you can get that into a better range in preparation for that surgery. Also, people with Loeys-Dietz syndrome tend to have weaker bones. So that's part of the syndrome and part of what goes on with the signaling pathway that is not signaling the TGF-beta signals the way it's supposed to. There are weaker bones, but if the bones are weak and there is poor nutrition, you get 2 hits to that bone strength, and it increases your risk of fractures by quite a bit. So if your bone density is also low on a DEXA scan, then it's important to also talk with a dietitian or a gastroenterologist about ways you can improve your nutrition as well. And we've seen that lead to increases in bone density just by improving nutrition. Very frequently in connective tissue disorders such as Loeys-Dietz syndrome, you will see constipation. Very frequently, we will have people use something called Miralax. Other names for it are Glycolax or Clearlax. The active ingredient is PEG 3350. This is a medication that does not work if you take it intermittently. If you only take it when you have a problem with constipation, you're actually going to probably get more trouble than not. If it's been long-standing, you may need to do a clean out beforehand. And if we have specific questions about that, we can go into that in more detail. Younger children, a step stool basically in front of the toilet so that their feet aren't hanging, can put those pelvic muscles in the appropriate position. That can help alleviate some of the problems with emptying the intestines when they have a bowel movement. Long-term constipation can lead to the muscles not acting properly. And very frequently when we see patients with Loeys-Dietz syndrome who are a little bit older, we see that they may have this pelvic floor dysenergy. This can be diagnosed with something called anorectal manometry, and it's treated with pelvic floor physical therapy. To be honest, however, anorectal manometry is not absolutely needed if you are someone with an older elementary school student who has had constipation for several years. Almost assuredly there is some pelvic floor dysenergy, and pelvic floor physical therapy can be really useful in that situation. Also, if you have a younger child who, because of their constipation, is having painful bowel movements and they're afraid to use the toilet, a cognitive behavioral therapist or CBT can be really, really helpful in those situations in order to create a situation where they're not afraid of using the toilet, which will obviously complicate the management of constipation. Lastly, there are disorders of gut-brain interaction. This is a newer name. Functional abdominal pain is a name, functional abdominal disorders. Irritable bowel syndrome. So these are situations where there is abdominal pain, but all testing comes back normal. It's really, really common in the general population. In some studies, up to 40% of people have one of these disorders of gut-brain interaction, but it tends to be more common in people with connective tissue disorders. We're here to answer your questions about allergies, GI issues, nutrition, ways to address bone strength with nutrition, disorders of gut-brain interaction. So we will stop sharing these slides and hopefully turn our video on and take your questions.
Thank you both. It's always so much great information. I'm always amazed at how much you pack into a quick, a quick presentation like that. We have a few questions in.
Angela, if you turn our video on, we will say hi to everybody.
Oh, wait, here we are again.
And I promise not to kick everybody out of the video again, for which I really am sorry, everyone.
Oh, it happens. Just 1 second. I am blinking on, I forget how to do this. Okay. While I go Google search that again, because I always make this mistake about how to make you be able to, wait a minute, maybe this is it. No, it's still not letting me do that. Okay, I will go figure that out. We have a couple of sort of like baseline questions that I thought maybe you could address, and then I will work on getting you visible here. We're just going to have all of the tech problems tonight. I like this question and thought I would pose this as sort of like a starting point with the Q&A, and that is, at what point does an intolerance become an allergy?
So they're actually very different things. One doesn't necessarily turn into the other. Food allergy refers to something very specific. It is mediated by a type of antibody called IgE, which is the allergic antibody. And with food allergy, the reaction will happen every time you eat the food, even if you only get exposed to a tiny amount of that food. And it causes very characteristic symptoms. So those are the hives, the immediate symptoms that usually happen within minutes, but usually no longer than an hour or two after you eat the food. So things like hives, trouble breathing, your throat, closing or swelling, those sorts of symptoms. That's a food allergy. And there are blood tests, there is skin testing we can do to try and detect those IgE antibodies to food. So the diagnosis is really based on the results of those IgE tests, plus your clinical history. A food intolerance can manifest many different ways. For some people, like with lactose intolerance, they'll have GI symptoms. Some people with an intolerance are able to eat a little bit of the food, and they only have a problem if they eat more of the food. So those types of symptoms tend to be a little more delayed in some cases. Oh, there we go. More delayed. And
We got to get rid of that.
can present a little bit differently than classic food allergy. Does that answer the question?
I believe so. Another one kind of on that food question or food panel kind of question here. This one is about an eczema flare. It says the pediatrician will not run a food panel for allergies, only environmental. Any suggestions?
Yeah, so it's very rare. We used to do food testing in people with eczema all the time. And in really young kids, food can be a trigger for eczema. But if food is the trigger, it's usually going to happen again, you're very early in life, usually in babies, 1 or 2 years of age. It will cause a full body eczematous rash, not, localized, and it will happen very clearly after they eat a particular food. So in the past, we used to do more food elimination diets as a treatment for eczema, where we would say, take all dairy out of your diet, see if the eczema improves. And then if it does, always do the second half of that experiment where you reintroduce the food to see if the eczema comes back. And we still do that occasionally. But what we learned is that by taking the food out of the diet, particularly in someone with eczema, they sometimes will develop that anaphylactic type allergy to the food. So it's important actually that we try and keep the food in your diet, if we can, to maintain tolerance to the food so you don't develop a more severe allergy. So people now that have eczema, we're much more reticent or hesitant to try and do food elimination diets because of that risk. So most people with eczema, over 90%, will have a positive test to one of the major food allergens. And that's probably why your pediatrician is hesitant to do it, because we don't know what to do with that positive test. As I was mentioning, a lot of people will have a positive test to foods that they are completely able to tolerate in their diet with no problem. And there is that risk that if we take out foods that someone tests positive to, they will develop a more anaphylactic type allergy to the food.
Okay, so a couple more on this, and then we'll move to a different thread here. Questions about can food allergies specifically, change with time in adults and or children? We've had a couple questions about that. One specifically citing had an allergy to strawberries, got pregnant, no longer allergic to strawberries. And then also a question about any specific antihistamine for food allergy exposure, kids and or adults.
Yeah, no problem. So food allergies can develop at any age. They peak pretty early in life, usually at about a year of age. We see a peak in the prevalence of food allergies. So most of them will develop early on in childhood. But we're seeing more and more people develop food allergies as adults. And interestingly, pregnancy tends to be one of those times where we will see, some adults develop new onset food allergies or have some of their food allergies resolved. So it's certainly something I've heard anecdotally. I don't think that we have a good mechanistic understanding for why that's the case, but we certainly do see that. As kids get older, they tend to outgrow their food allergies. So we generally see numbers in their testing increase between the ages of 0 and 3 years of age. And then after about 4 or 5 years of age, many kids will start to outgrow their allergy. That group of adults who do develop new allergies, when they're older and didn't have any problems as kids. And then in terms of what antihistamines to use, we used to say to use Benadryl in the past, but we know Benadryl can make you sleepy. And so now, even in our food challenges, we're starting to do more and more work with Zyrtec, cetirizine, or Allegra, fexofenadine. So those, I think, are fine substitutes to use instead of Benadryl and shouldn't cause the increase in sleepiness that can occur with Benadryl.
Okay, switching now to some colon questions. Inflammation of the colon, is this a common part of LDS? What is a solution? And then this person is saying, I've had 2 scopes, both just showed inflammation, so wondering what's causing it. And then another question about colonoscopies, if Loeys-Dietz patients are at higher risk for puncture, and if so, are they still then recommended?
Okay, so the first question in terms of inflammation seen during a colonoscopy. So there's different kinds of inflammation in the colon. So I mentioned the eosinophilic GI disease. So there's eosinophilic esophagitis, which is eosinophilic inflammation in the food pipe up here. But people with Loeys-Dietz syndrome, or at least types 1 and 2, are more susceptible to eosinophilic inflammation throughout their GI tract. So they can get eosinophilic inflammation in the colon as well, called eosinophilic colitis. There's another inflammatory disorder of the intestines called inflammatory bowel disease. And it turns out that people with Loeys-Dietz syndrome are more susceptible than the general population to also develop inflammatory bowel disease. It's not everyone with Loeys-Dietz syndrome. It seems to be about 5% of the people in our study with types 1 and 2 had developed something called inflammatory bowel disease, or IBD. And IBD is where your white blood cells are confused and they think there's an infection in the intestines when there isn't one. And so they end up running around and the lining of the intestines gets damaged as a result. The diagnosis of inflammatory bowel disease is with someone with Loeys-Dietz syndrome is the same as someone without, and that's a colonoscopy with biopsies. And the treatments are also the same. And there's lots of different treatments for inflammatory bowel disease, from pills that you take to shots that you give yourself at home to infusions that you give. So the question, the person who asked about having inflammation on the scopes, it would be to discuss with your gastroenterologist whether this is consistent with something called inflammatory bowel disease. And the two types of inflammatory bowel disease are Crohn's disease and ulcerative colitis, and those are different forms of inflammatory bowel disease. But if it is, the treatments, whether or not you have Loeys-Dietz syndrome or not, are the same. If you want to put your gastroenterologist in touch with me, please feel free to do that. I'm happy to talk with them. And I think that goes with Pam as well. If any of you have any allergists who would also like to talk to us about these specific questions in Loeys-Dietz syndrome, we're always happy to talk to anyone. But the intestinal inflammation, if it is inflammatory bowel disease, it needs treatment, and it needs the same treatment as otherwise. You might, because Loeys-Dietz syndrome is a connective tissue disorder, you might suspect that people with Loeys-Dietz syndrome are more susceptible to perforation or breaking of the intestinal wall when you're doing the colonoscopy. We have not seen that. There is an increased risk in another connective tissue disorder called vascular Ehlers-Danlos syndrome, not hypermobile Ehlers-Danlos, but vascular Ehlers-Danlos. But we do not see this increased risk in Loeys-Dietz syndrome. And I've done dozens of colonoscopies in people with Loeys-Dietz syndrome and have not had a perforation in any of them. So there does not seem to be an increased risk. So if a colonoscopy is called for, then I think you should have one. The things that I do tell when people call me are, if they need a colonoscopy, are one, it should be done. So you can do a colonoscopy in an ambulatory surgical center. I do tell them I recommend that they be done in a hospital setting with an anesthesiologist. We want good control of the blood pressure. We don't want it to spike. We don't want it to go too low. So I do recommend that endoscopic procedures, colonoscopies or upper endoscopies, be done in a hospital with an anesthesiologist. And I recommend that with Loeys-Dietz syndrome, there can be some cervical instability in the neck. And I do recommend that you just be aware of that. Having cervical instability is not a contraindication. It's not a reason not to do it, but you do want your gastroenterologist to be aware of that, just so they don't put your neck back too far when they're doing an endoscopy. And then the last thing is that there are some bone weaknesses. So if they do have to move you around during the procedure when you're sedated, they're just aware of that to be gentle, as there is an increased risk of fractures. But again, we do not see an increased risk of perforation.
Thank you for that. And I just want to say thank you also, because you both are so, you've always made yourself so available to people who have questions about these topics. And I know it's been such a relief and such an assurance to so many. So thank you. Kind of on this associated conditions thread here, a lot of questions about a link between LDS and celiac disease. And then also we have a question about any connections between LDS and EOE.
So there is a connection between Loeys-Dietz syndrome and eosinophilic esophagitis. We showed that in our first, the paper that Pam referred to. So people with EOE are more susceptible to developing eosinophilic GI disease. Eosinophilic esophagitis is the most common, and it is the most common in Loeys-Dietz syndrome. We did look for celiac disease in that first study in quite a number of people with Loeys-Dietz syndrome types 1 and 2, and we did not see an increased risk of celiac disease in Loeys-Dietz syndrome. Now, celiac disease is very common, so you could have both, but celiac disease does not seem to be associated with Loeys-Dietz syndrome.
It's one I know we get that question a lot, and so I'm sure you get asked it a lot as well, and it does seem like it would follow, but I know I've heard you say several times that despite that, no real link we're seeing so far.
The one caveat though I want to bring up is that most of our information about the prevalence of these conditions is really, again, in type 1 and 2 LDS. I'm hesitant to say that that's going to be true of all forms of Loeys-Dietz syndrome. It's really a question that we're prioritizing to answer so we can give better advice to people with other forms of LDS that were described a bit later. So again, a lot of what Tony and I talked about in our slides and how we're answering questions now is based on our clinical experience, again, with people with type 1 and 2 LDS.
And you know, just to sort of, there's a question about the study at the NIH. You know, this is, as you're listening to, you know, us talk, and you know, you have an opportunity to come to the NIH. You're going to be in the area because you have an appointment at Johns Hopkins and you're seeing Dr. Dietz and his team. Please, you know, see us, come to the NIH, you know, contact us. So even if you don't have these problems, it's actually really, really helpful to see people who are doing really well and not having any problems, because it allows us to take your information and say, no, we can tell you, you know, there's not an increase of celiac disease. There's not an increased risk of this. And we can only do that if we see as many people as possible. You know, and right now, you know, the later types of Loeys-Dietz syndrome, we're really needing you all to volunteer to send us your information to come see us, so that we can answer these questions for everybody in these webinars. So that's just a commercial, I guess, for us.
It's definitely an important commercial to share. And thank you for mentioning that. We also had a question submitted about small intestinal bacterial overgrowth, if there is any, you know, something linked, or is it more frequent occurrence in LDS versus like an otherwise healthy population?
We have not seen an increased risk of Loeys-Dietz syndrome, of small bowel overgrowth in Loeys-Dietz syndrome. There are a lot of symptoms that get blamed on small bowel overgrowth. There's testing you can do to define whether or not that really is the problem. And I just want to make sure that your doctor has actually done the appropriate testing, rather than sort of blaming it on that without looking more deeply. But if they have, there are treatments that are appropriate for small bowel overgrowth, but it's not something that we see specifically with Loeys-Dietz syndrome.
Okay. Several questions about sort of like general weight gain. I know you touched on that. So if we could expand a little bit on, you know, aside from Miralax, exercise, fiber, for kids or adults, where, you know, like if you've tried those things, like what's the next thing?
Yeah. So again, constipation is a really common problem in connective tissue disorders. It can really make sort of your daily, your days difficult, right? Because, you know, you have to have a bowel movement every day. And if part of that day is spent with something that's frustrating and difficult, that really can impact your quality of life. So important things are the Miralax has to be used daily. You have to almost always precede using it daily with a clean out. So a small daily dose keeps the new stool soft. It doesn't do anything about hard stool that's already in the large intestines. And so you do need to do sort of a clean out to sort of reset things. Exercise is certainly important, both for constipation, for disorders of gut-brain interaction, for joint pain that you can get in connective tissue disorders. Daily exercise is super important. And then beyond that, if this has been a long-standing problem, as I mentioned, there is almost assuredly there's 3 sets of muscles that have to coordinate when you have a bowel movement, and 2 of them have to contract and 1 has to relax. And if they're either all contract or all relax, you can't have an effective bowel movement. So pelvic floor physical therapy to retrain those muscles can be really crucial in terms of getting all those muscles to work together properly. And so if you've had long-standing constipation, and which I mean long-standing constipation is like a year or more, pelvic floor physical therapy can really, really help.
The thing I would add is if it's trouble gaining weight, that's a concern. You know, again, that's one of the symptoms of undiagnosed eosinophilic esophagitis or eosinophilic GI disease. So if you have that as a symptom and no other cause has been identified, it is worth seeing a gastroenterologist to get testing to make sure that that is not what's driving your poor weight gain.
The tricky part becomes there's a subgroup of people with Loeys-Dietz syndrome and also Marfan syndrome that when they're little just don't put on subcutaneous fat. It's well described sort of in the community, but it's not really understood the mechanism for it. It goes away in your 20s. But when you're a little kid, it doesn't matter sort of how many calories we try to pack on. There's just this real difficulty in putting on weight and teasing out whether or not there's some underlying issue that needs to be addressed, or you're one of these people with just this inability to put on subcutaneous fat is super hard to untangle sometimes. And I'm happy to help anyone sort of if they want to send their doctor to talk to me, but there are a group of people with that.
When it gets to the point that a child would need a feeding tube, like ages 2 or 3, because of they're not able to gain weight, should they expect to have that tube for life, or is that something they might grow out of?
Almost always they're going to grow out of it. It can be really helpful to have a feeding tube basically while you're growing. But once you're done growing, the number of calories you need sort of proportionally for your body weight, right? So when you're first born, you need like 100 calories for every kilogram of body weight. When you're older, you need 25, 35. So the total, while the total number of calories increases, the amount you have to eat for your size goes down dramatically. So of the people with Loeys-Dietz syndrome that I've treated who have needed a feeding tube, once they're done growing, I think all of them have, all of them have had it removed once they're sort of done with their teenage growth spurt. So, you know, for girls, that's about 15, 16. For boys, that's a little bit older, 17 or 18, but they've all had it out and they've done just fine.
Yeah, I think we can say we've had a lot of patients that have needed the feeding tube, and there's always a lot of hesitation, understandably, I think, from the families when we put that in. But I think once it's in and you see how well the child does and how much better they do with their surgeries and how much more quickly they recover, I think it's usually seen as a good decision.
That's a hopeful outlook. I was wondering that too, if they all have outgrown, and that your confirmation there is great to see. How about treatments or medications to identify or alleviate with chronic diarrhea?
I think there again, I think a GI workup would be the first step to try and understand the reason for that.
Yeah.
You know, is this due to underlying inflammation in the GI tract? Is this irritable bowel syndrome? It would really depend on, I think, the cause for the diarrhea, how we would approach the treatment of that.
Yeah. So, the first place it needs to start is with blood work, and some stool testing. It is very likely going to need an endoscopy and a colonoscopy to evaluate. But the number of things can cause that is quite wide, and can be fixed, but with something as easy as modifying your diet. But it can also be a sign of this inflammatory bowel disease, or IBD, that I mentioned. In a younger child, it could be a sign of eosinophilic colitis, or this allergic inflammation in the large intestines. And so it does need a workup.
Would you say the same for chronic or even like periodic vomiting?
Absolutely. So if you have chronic vomiting, that absolutely can be a sign of eosinophilic esophagitis. The other thing it can be is a problem with how the intestines are sitting. So for who's ever asking this question, if you have you or your child has chronic vomiting, your doctor should have at some point gotten a test called an upper GI X-ray study. It's an upper GI X-ray study, not confused with an upper GI endoscopy. It's an upper GI X-ray test where you drink some barium and they take an X-ray while you've drunk it to make sure that the intestines are sitting in the right place. It's to rule out something called malrotation. You only need one in your life. If you've ever gotten one upper GI X-ray study to rule out malrotation, you don't ever need another one, but you need at least one if the problem is chronic vomiting.
Very good. Okay, I think my pre-submitted questions are mostly covered, so we'll go fully into the Q&A here. I did see a few questions pop up on more details around EOE. What are the tests to diagnosis, and is treatment for EOE the same for LDS patients as typical population?
You want to start?
Yeah, so the way we diagnose EOE, the only way to diagnose EOE, unfortunately, is with an endoscopy, where we do the scope, a camera inside the esophagus, and we take a little piece of the tissue and we look at it under a microscope. And normally an esophagus in humans doesn't contain any of those allergic cells, any eosinophils. And you have EOE, the diagnosis requires the presence of more than 15 of those allergic cells when we look through the microscope. So the way to diagnose it is with an endoscopy. In terms of treatment, we treat it exactly the same as we do people who don't have Loeys-Dietz syndrome. And we have found that patients generally respond well to those treatments.
Okay. Can you develop eczema at any age?
You certainly can. So we see it develop in young babies, but we also see adult onset eczema. So there's no age limit for when you can develop it.
How common is mast cell activation syndrome in LDS?
That is something that we actually looked at in our study at the LDS, and it's actually extremely uncommon, at least in type 1 and 2 LDS. It is more common in other connective tissue diseases. So I would say the hypermobile type of Ehlers-Danlos, I think there is a higher rate of mast cell activation syndrome in those patients, but we have not seen an increase in mast cell activation in people with LDS.
We've had a couple of questions. I see Julie, I know Lincoln has tree nut allergies. So asking about a young child with type 2, when would you use an EpiPen? Would you not use an EpiPen? At what age would you do a food challenge to see if he's grown out of it?
Those are all good questions. So in terms of when to use an EpiPen, if they have a reaction that is mild or localized, and what I mean by localized, they have maybe hives at one part of their body, and that's their only symptom, or they only have itchiness in their mouth, or they had one episode of vomiting, for instance, then you could try treating with an antihistamine, something like the Zyrtec, Benadryl, or Allegra that I mentioned. But if they start to have difficulty swallowing or breathing, or there's two systems involved, or they have hives involving their whole body and they're vomiting, so it's both GI symptoms and skin symptoms, that's when we would go ahead and use the EpiPen. And then I forgot, the second question was about food challenges. So food challenges, that is where the allergy testing does come into play. So we have pretty good cutoffs for when we would do a food challenge for tree nuts. And so it's really based on their history of reaction to the tree nuts, whether they've ever eaten them, and if they have, what their reaction was, the type of reaction they had, how long ago that reaction was, and what their IG level to that tree nut is. So it takes into, I guess, incorporates a few pieces of information, but we would generally check the IG levels about once a year and make that decision again based on the clinical history when to offer a food challenge.
Also on that same one, if they're using Zyrtec, like what kind of dosage do you typically recommend in little guys like that?
Yeah, that's based on age. So in the youngest kids, I think it's about 2.5 milligrams. And then I'm forgetting the age cutoffs off the top of my head, but it goes up to 5 milligrams and then 10 milligrams in adults. I can get back to you exactly with the age cutoffs for that.
Is that the same as general population?
Yes.
Okay.
Yeah.
Just remembering from my kids' little days, that sounded familiar. Question I missed in the pre-submitted ones about dealing with a stoma. The person says, I have an ileostomy that was temporary, but the reversal surgery was unsuccessful due to surgical error. It's now permanent.
And so I'm trying to figure out the best way to answer this. So if the only, is it I think we need some more details to answer this. Is the ileostomy permanent because they had to remove the colon? I can't think of a technical reason why there couldn't be a second try to go back and reverse an ostomy.
Unless there's scar tissue or.
But even if there's scar tissue.
Yeah, we might need more details on that.
We either need more details or you need a second opinion. I need more details. I'm so sorry.
The person who asked that question is on tonight, so I just messaged them separately. How about, I know we've had this one before too. And I think this is a good conversation. At what point do you decide a child needs a feeding tube? This example is a 7-year-old that's really struggling to put on weight.
So here are sort of my thinking in terms of a feeding tube. So I mean, the first is if the person their body mass index is dropping percentiles. So body mass index is something that your doctors should be plotting at every visit. And they should be telling you what the percentile for the body mass index is, because it changes with age. You can also type into Google CDC children body mass index calculator, and you put in the height and the weight, and it will spit out the percentile for you. If that percentile is dropping, if it's going from 24% to 11% to 3% to 1% to 0.1%, and they've done your doctors have done an appropriate workup, and there's, whatever they've found has been addressed, but it's still dropping. Or if it's persistently below the 3rd percentile and there's a surgery planned, they're saying, okay, next summer we're going to have to do aortic root surgery. Or if you are spending 3 hours 3 times a day fighting with a toddler to get them to eat enough, and all you're doing is spending your life and your whole interaction with that member of your family is conflict, trying to get them to eat one more whatever, then I think you need to talk to someone about a feeding tube. I will tell you that different institutions have different sort of cultures. At Johns Hopkins, we put in feeding tubes through the skin into the stomach pretty readily. Other places less so readily. A feeding through tube into the stomach, we think is more convenient for families and patients in terms of using. They're more stable. They're less likely to have complications from them. For older kids and older teenagers who might need a feeding tube, an NG tube or a tube through the nose down into the stomach that someone would put in the evening. They would run a feed overnight with a pump. And then in the morning, they take the tube out and they can go to school and nobody knows. I've had patients do that as well with good with good results. If you're going to do that, it's really important that the person be able to put the tube in themselves. Lots of teenagers can do that. I have had one 8-year-old be able to do that themselves, and they did not want a feeding tube through the skin. They did not want to go to school with a feeding tube, and they learned how to put a tube in their nose, and they did overnight feeds. It's hard to do that with a real little kid because they keep pulling out the tube, and then every time you have to put it back, it's a giant fight to put it back. But those are the three sort of situations where I start talking about a feeding tube with a family.
Okay. I have one more question. I think we're probably getting into some solid specifics here with the remaining questions, and I want to be conscious of the time here, everyone's time. But there was one in the chat that I thought I would bring up, and it says, our allergist said the FDA is going to release 2 new Epi Delivery Systems, a nasal spray and a strip that goes under the tongue. Will these be a better option for Loeys-Dietz patients?
Yeah, the FDA is actually reviewing those, I think, very soon. They're not approved yet. I think the reason that those methods of delivering epinephrine were developed is because of hesitancy among people, and not just people with LDS, but really just general kids and adults in general, about using an epinephrine pen. It's a little intimidating to inject yourself with a needle. And so I think there was a lot of interest in trying to find other ways to give the medication in hopes that people would not be so hesitant to use it when they need it. It doesn't mean that it's necessarily going to be safer for people with Loeys-Dietz. So the reason epinephrine, again, is potentially a problem in someone with Loeys-Dietz is that it does increase the heart rate. It does increase your blood pressure. So if you have aneurysms, if you have vascular issues, that that is not a desirable effect. That being said, epinephrine you make normally in your body. So if you exercise real hard, your body's making epinephrine. We certainly have given epinephrine to many kids and adults with Loeys-Dietz and haven't had any problems. So, we use it judiciously. We're cautious about it. We don't give it unless it needs to be given. But it is generally safe to use. And like I said, we haven't had any bad outcomes from giving someone epinephrine that I'm aware of to date.
Angela, we're happy to answer questions for a few more minutes since the technical problems at the beginning kind of our fault. So
okay,
are you stay a little bit longer? Are
the two of you able to access the Q&A there, or some of these?
It's up to, yeah.
I'm going to be easier for you to read if you want.
There's someone asked about. It looks like there was someone had a colonoscopy and there was inflammation in the terminal ileum. And then a follow-up colonoscopy 6 months later. So I'm assuming that they saw inflammation in the terminal ileum, that they saw acute inflammation, but not enough to make a diagnosis of inflammatory bowel disease. In that situation, I typically would wait 6 to 12 months before repeating the colonoscopy. If symptoms are progressing, I'll do it closer to 6 months. If things are not progressing, i.e. symptoms are not getting worse, I will try to wait as long as 12 months before repeating it. So 6 to 12 months is very, very reasonable. But again, if things are not progressing, I would try to wait closer to 12 rather than 6. MRI enterography for an 11-year-old is reasonable to do at that time, and it's very helpful in the diagnosis where you have inflammation in the terminal ileum. A mature 11-year-old can likely participate in an MRI enterography. I think it is worth trying to see if you can get good images. As you all know, an MRI test, if you move around during it, you get blurry images and it's hard to see. But that sounds reasonable to me.
Looks like we have another question about abdominal pain that got worse. It's been long-standing for many years.
Okay. So someone with stomach pain progressively gotten worse over the last decade and a half. Bentyl helps. So this is a super difficult. There's a lot that can be causing this pain. It definitely needs a workup. It definitely needs an endoscopy and colonoscopy, and probably an MR enterography is what I would do. The fact that so the way Bentyl works by paralyzing the intestines. And so the fact that Bentyl is working does point towards two possible things. It does point towards constipation as a possible reason for the pain, but then it also does point to one of these functional abdominal pains, these disorders of gut-brain interaction, or irritable bowel syndrome is one of the other names, older names that it goes by. Again, because if Bentyl is working, it's working because it's paralyzing the intestines. And with these disorders of gut-brain interaction, what happens is with normal peristalsis, normal action of the intestines pushing things along, those signals are inappropriately interpreted by the brain as a painful stimuli. So what I always liken it to, like someone who's gotten a burn on their hand, and the skin heals completely, but when you run your finger across that part, it feels like your finger's made of sandpaper because those nerves are hyperexcitable. An infection can certainly be a trigger, just like a damage to the skin can be a trigger for those nerves being hyperexcitable. An infection can be a trigger for the nerves of the intestines to be hyperexcitable and send a signal of pain when they're pushing food and air and water and fluid along. And so, I think it definitely needs a workup. If that workup comes back negative in terms of blood work and stool testing and endoscopy and imaging, then it's very possible this may be one of those disorders of gut-brain interaction. And there are lots of ways that those can be addressed, but that's the sort of workup that I would take for those lines for that.
I had a question about a 2-year-old with type 3 LDS who had a bad allergic reaction to ibuprofen with face swelling. And their question was, is this common in LDS and is this a lifelong allergy? So I would say we really did not see an increase in allergy to medications in our initial study looking at allergies. It was really more food allergy. It's something that I think we do need to look at more closely. We certainly see these types of allergic reactions to ibuprofen in the general population. And the good news is that most people will outgrow that. So I would suspect that would be the case with LDS as well.
Our person with the question about the stoma came back and said, is there an extra risk of a failed
anastomosis due
Sorry,
to
it's on my other screen and it's far away and I couldn't see due to LDS. Yes.
So
yeah, it's a good question. I mean, we see poor wound healing after surgery for hernias and things like that, but I don't know about anastomosis per se.
The number of patients that I can think of with anastomosis is really, really small. Now, we have had patients with poor wound healing and hernias in the skin, but that's more of a fascial issue. I cannot think of a problem with an anastomosis with LDS. The number would be really, really small. I don't even have like a case series set of numbers. It would be, a sub 5 numbers of people who had an anastomosis. There is a risk of an anastomotic failure of the colon in vascular EDS. And what may be happening is the surgeons are generalizing from vascular EDS to Loeys-Dietz syndrome. And the risks are different. We do not see an increased risk of colonic perforation in LDS. We do in vascular EDS, but not in LDS. That's the best I can answer that question at this point. I'm sorry. That's the best I can do. We do not see it. My numbers are very, very tiny. But given that we don't see an increased risk of perforation, I can't think of an a priori reason why there would be an increased risk of a failed anastomosis.
Somebody asked about an increased risk of endometriosis, and I'm so glad they asked that, because I think this is an area that we really need to learn more about. At this point, we don't have any information whether that is the case or not, but I can tell you in our study, we are seeing more and more LDS patients who are having complaints consistent with endometriosis, abnormal uterine bleeding, ovarian cysts. I think it's something that we need to look more carefully at. And I believe there is a study at Hopkins looking more into pregnancy.
No, it's pregnancy. Yeah.
But it's something that we're starting to pay more attention to. And I think at some point we may need to get a gynecologist involved to really look at this more systematically, because my suspicion is that there is something there, but I don't have any hard data to share with you at this point.
The question about abnormal fecal fat and low stool pH. The low stool pH is a really, right, if the stool is sent off, the bacteria in your poop, they're still alive while it's being shipped through the mail. And so they're still fermenting things and creating acid. So low stool pH is really something that has to be tested, sort of like, this is gross, but with a fresh stool sample, you can't send it somewhere and test it. You have to test it right then. The abnormal fecal fat, though, that's a valid test to do and send, and is something that should likely be followed up on. But I don't send the stool pH for the reason of you have to do the test right there. You can't send it off. But the abnormal fecal fat, there are things that should be looked at in terms of, you can look at pancreatic enzymes in the stool and see if there's enough of them there. There's some endoscopic techniques to look at the pancreatic, a pancreatic stim test to see if the pancreas is producing enough enzymes. And there's also just a trial of pancreatic enzymes to see if that helps. But most people are going to want to do one of those two tests, either a stool test to look for pancreatic fecal elastase, or a endoscopic pancreatic stim test.
Okay, I think that catches us up with everybody. And once again, I'm just so grateful to both of you. I'm so glad we were able to find a time to get everyone together to talk about this topic. Once again, if you have other questions, either that we did not get to, or we didn't answer exactly how you meant, or just other things come up, please contact our on-staff nurse. It's at loeysdietz.org/ask. And she will either know the answer and connect you with resources, or reach out to Pam or Tony. We'll find a way for you to get the information that you need as best as we can. And, you know, that's what we're here for. We are so fortunate as an organization to have the support of doctors like these and others in other specialties too. So it doesn't just have to be gastro or allergy questions, but thank you for everyone who attended. We will be sending out a link with this recording, maybe a mashup of the first recording and this one, so we get it all together, all in one place. But yes, thanks for sticking with us through the technical difficulties. I liked what you said, Tony. You would have thought like through COVID, we would have had this all figured out, and still it's still sometimes it trips us up, but that's the nature of the beast. So with that, I just want to say thanks again. Have a great rest of your day wherever you are. Reach out to us if you have more questions, and thank you.
You're welcome. Thanks, everybody.
Thank you all.
Bye.
Bye.